Good evening, and thank you for joining us for yet another exciting talk in this lecture series that we have organized as part of our collaboration with the Pakistani Society of Medical Genetics, University of Health Sciences at Lahore, and Janassan Medical University alumni of North America. A few housekeeping rules that we have for us today, as per usual. Ensure that all audience members are muted, as well as questions are posted in our chat box. And at the end or in the middle of our talk today, I will be posting a link to a Google form, and I would really appreciate it if you can all take a minute to fill that out, as that is our only way of getting your feedback and comments and questions. And to see what interest we're generating by having these lectures. So it is with great pleasure I would like to introduce Dr. Hamachima. She is a pediatrics, gastroenterologist, and hepatologist. Amongst many accolades, she is also the director of pediatrics liver transplant in Lahore, the chairperson of Pakistan Pediatrics Gastroenterology and Hepatology Association, as well as the distinguished honor of being the founder of Rare and Genetic Diseases Center at Children's Hospital in Lahore. And so without any further ado, take it away, Dr. Chima. I will stop sharing my screen.
Can everybody see that?
Yes. Yes, looks great. Thank you so much.
Okay. Right. So the topic which was given to me by Aisha today is a very big one. So I'm going to try and do some justice to it. But I think this is a topic which was very much needed. And a lot of doctors have requested this topic before as well. So I think in the interest of time, I'll be skipping over some slides. You asked me to give some examples from Pakistan, which we had plenty. So we'll, if somebody has questions about something, you know, I cannot be totally comprehensive, so we will go over them at the end. For everybody, beautiful Pakistan. And as I can start by saying that nothing is possible without a good team, and that's my team with Professor Antrovs, who has been collaborating with us over the past 7-8 years. Now, we do have a huge burden of infectious and communicable diseases in Pakistan and malnutrition, like any other developing country. But our biggest issue, which we have been facing increasingly in the specialities, is this big burden of genetic diseases. We are a very highly inbred community. We marry our cousins, we marry the same caste. And this is an unrecognized burden by the policymakers. And cumulatively, the genetic diseases, they cause a huge mortality in the first year of life. So you can see that we have every sort of genetic disease. Successive governments have had no planning or focus on prevention of disease. We don't have a lot of centers to treat these rare disorders. And for patients of, let's say, inborn errors of metabolism, they suffer from rare genetic disorders, and it's a virtual health pilgrimage for them. They travel up to 18 to 22 hours. Children's Hospital, to show, this is for my colleagues abroad who haven't seen it. I hope that you can come over one day and visit the Children's Hospital. It houses over 40 subspecialties. How did I, as a gastroenterologist, got involved? You can imagine a lot of these inborn errors would have either the liver derangements or hypoglycemia, or like the LSDs would have hepatosplenomegaly. A lot of the times, about 20 years ago, or I would say 15 years ago, they were given terminal counseling. There was no access to metabolic screening, genetic testing, and many patients' parents had lost a lot of kids. We'll come to that at the end, that we have been very, very lucky in this collaboration, and we have been testing across the country in various main cities of Pakistan and diagnosing a lot of these disorders. So coming to the inborn errors of metabolism. These are genetic disorders that disrupt biochemical processes in the body by altering either the enzyme activity, a cellular transport, or mitochondrial bioenergetics. And I would not, I love this saying by Eliot that, we shall not cease from exploration. At the end of all our exploring, we'll arrive where we started off. And this is like so true in so many diseases that we see in the genetic diseases and inborn errors. Till 1942, we didn't really know about a lot of inborn errors of metabolism. And I think phenylketonuria was the first one when Dr. Bickel from Germany, he showed it to be a treatable disease by early diagnosis and by good dietary management. Now, with increasing recognition, at the moment, I think there are over 600 inborn errors, some less common, but again, individually, they may be less common, but cumulatively, they have a huge impact. Now, inborn errors are disorders in which there is a block at some point in the normal metabolic pathway. They will occur due to mutations in DNA, which code for a specific protein, which might be an enzyme, which might be related to a receptor, a transport vehicle, a membrane pump, a structural element, which will produce ultimately this inborn error of metabolism and its consequences. So when should we suspect an inborn error of metabolism? I think it's very important in a country like ours, even though there is a lot of mortality early on in infancy, that if there is history of death of siblings, or there is a child who has symptoms which accompany change of diet, or there is recurrent admissions with sepsis-like illness, or you see the file and you see that there is some metabolic acidosis documented in some admissions. Children who have seizures, developmental delay, regression of milestones. This particular group, sadly, I have to say, a lot of them come to us with a diagnosis of cerebral palsy. And if you see a patient and who has already had a family who's got one child with cerebral palsy labeled already, be wary of labeling another one as cerebral palsy and think of inborn errors. Recurrent vomiting, admissions with vomiting and altered liver functions or low blood sugar. You've got to think of inborn errors of metabolism. It's very interesting that we also have the fructose intolerance gene, and we have recently diagnosed just on the basis of vomiting and aversion to fruit. So think about inborn errors of metabolism. Unusual odor of urine. I have to say my nose is pretty bad, so unless the parents complain of it. Parental consanguinity, well, it exists in 80% of our couples. Problems in other cousins. So you might have acute signs in patients, or you might have chronic signs. So acute we are familiar with. They come in with vomiting, shock, lethargy, coma, blood sugar low. Chronic signs are there: failure to thrive, developmental delay. We recently diagnosed 2 children with failure to thrive and vomiting, and they had lysine-uric protein intolerance. So hepatomegaly, cardiomyopathies, spastic diplegias, just not everybody is a cerebral palsy. So you might have a child who comes to you with a picture of encephalopathy with or without metabolic acidosis. He might have evidence of acute liver disease with some cholestasis, or might be in hepatic failure, might show low blood sugar. He might have dysmorphic features, and we won't go into the details of these today, as I will come to it. These things like peroxisomal disorders and Zellweger's and the mucopolysaccharidosis. You might have a cardiac disease like in fatty acid oxidation defects or GST type 2, or hepatosplenomegaly like the LSDs, or a very predominant neurological symptoms in amino acidopathies, or even in fatty acid oxidation defects, or the newly understood disorders of creatinine synthesis, where predominantly you just have neurological symptoms. There's a huge daunting list of inborn errors of metabolism. So I think today we'll be focusing on the common ones which we can focus on today, because we can't really realistically speak about all of them. We will also give you some real life scenarios and examples from our own practice. So we'll focus on the groups of organic acidemias, disorders in amino acid metabolism, urea cycle disorders and consequent high ammonia, disorders of fatty acid oxidation, the lactacidemias and the mitochondrial diseases. There are other inborn errors, and these are the way we group them. So I thought we'd put in the other groups as well, the mucopolysaccharidosis, the disorders of carbohydrate metabolism, which are very, very common, the lipid storage, in which you will have Fabry we don't see a lot because in pediatrics, maybe under-recognized, but GM1, GM2, Tay-Sachs, Sandoff, Gaucher, Niemann-Pick, Wallmans. We recently diagnosed a monocytosis, which looks like phenotypically like a MPS, galactosialidosis, paroxysmal disorders. But these two slides I won't be discussing today, and we will be going towards the organic acidemias and the slide, the fatty acids, amino acidopathies. So how do you approach a child? I'll talk about one such child to you who is suspected to have an inborn error of metabolism. Now, this is a real child. A 2-month-old is brought to our emergency with a history of vomiting, lethargy, altered sensorium, and respiratory distress. Vomiting is so significant that previously he was investigated as a suspected pyloric stenosis. There is past history of a SIB death at 8 months, product of a cousin marriage. You are called in because the initial ABG shows metabolic acidosis. Now, always the question to the residents is, or to the practicing pediatrician in the periphery, what further investigations should you do? How will you manage this particular baby? What do you think is the most likely diagnosis? So you can plan some investigations. So I think going forward to saying what tests should be obtained in all such babies with suspected inborn errors. You got to do a complete blood count. You might have cytopenias, inorganic acidemias, particularly methylmalonic, propionic, isovaleric. You got to obviously, he looks acidotic, is tachypnic, take your ABGs, do your electrolytes, get your blood sugar, get your plasma ammonia. It's very important to take the appropriate fresh sample in and put it in ice. Get your blood lactate. Now labs do it, but frequently this is a missed investigation. And we'll come to it why it's so important. Get your liver functions. Collect urine, the initial one, for urinary ketones. And also, you might need urine reducing sugars. Now, for this particular baby, the CBC showed pancytopenia. This is the actual baby. Severe metabolic acidosis with a very low bicarb. The serum ammonia report is there for you. Blood sugar was 50 and the urine ketones were 3+. Now, what do you think this child has? Now, most of you who are listening will have framed the diagnosis and said, okay, so it's one of the organic acidemias. So I think most of you are right. So let's look at, so I'm going to be going back to this slide again and again for you, so you practically know the algorithm. So you have the one, look at on the right side, you have a metabolic acidosis and you have an anion gap there. Now, why do you have an anion gap there? Sorry. Is because you have, sorry, what is happening to this? You have other organic acid, lactic acids, you have them which you are not calculating in the, and there's a huge gap there, which shows that you have other acids over there. So you will then look at whether you'll send a lactate sample, you will take an ammonia. Now, if you have raised ammonia along with metabolic acidosis, then it's important to do your lactate. If you don't have the lactate immediately, still, you are right in thinking that, yes, you will go towards the algorithm of organic acidemias, but you don't have the urinary ketones available immediately. If the ketones are present, you're not talking about a fatty acid oxidation defect, but if they are present, you're going towards organic acidemias. Now, MSUD will come to it. It is classified or treated like an organic acidemia, even though it's a disorder of the branch chain amino acids, and strictly speaking is an amino acidopathy. So in this particular child, the common organic acidemias are the propionic acidemia, the methylmalonic, halocarboxylase, multicarboxylase, and biotinidase deficiencies. We put them in the same category, the isovaleric and the various glutaric acidurias. Now, what are the second line tests that you would like to do? These tests must be performed in a targeted manner. I think you must talk to a resident who is listening, must talk to his senior consultant to think like what further tests must be done. If you can't do them immediately, save the sample of urine to send for gas chromatography, GCMS for organic acids, save the sample for plasma quantitative amino acids. We don't have the SL-carnitine profile being done over here, but in suspected fatty acid oxidation defects, it's a very important test. And so for the quantitative plasma amino acids, you can save the blood for that. The plasma is needed. And you can also have some blood, some 3.5 cc in EDTA saved up to send to us for genetic testing if you're highly suspicious. It's very important to look at the lactate to pyruvate ratio in cases if the lactate is elevated. Now, most of the time, I put this in, the reason being that people talk about enzyme assays in exams still FCPS. They're not available for most inborn errors, and the ones in which it is available, it's the biotinidase assay, and in suspected cases of biotinidase deficiency, we'll come to that, and the galactose-1 uridyl transferase in galactosemia. So it's important to get these tests, and I think lactate we should go as the first line, but the second line test you can save blood if the first line are going to come positive. Now this was back to our index patient. We sent the quantitative plasma amino acids, and I highlighted for you that there is high glycine, and the urinary organic acids show propionic acidemia. So, and we also did the genetic testing and we confirmed the propionic acidemia. Now, so therapy was started we sent this patient, I think this patient was diagnosed somewhere else and came with these pictures, if I'm not mistaken. So this, when they start, the doctor in the periphery or wherever, they started the therapy, and he was brought to us with this. At my first look, I first thought I'm dealing with inborn error, which has rash due to the inborn error. But on investigation, what happened was that this was the reason that the baby was having these rashes. Now, I thought I'd put this in because it's so important to understand that a lot of people in good faith are completely obliterating all the protein if suspected of any inborn error of metabolism. And this is a protein-free powder which is available in Pakistan, and this is used in the patients, and the physician tells the baby's parents that they are to take solely this milk. Remember, it is never ever to be a totally complete protein-free diet. In fact, even in crisis, we tell you that more than 48 hours without any protein is not safe. So this kid came, most of them come to us with this protein deficiency rash, low albumin, edema, and anemia. Now, this is him after good treatment. So the treatment for such a patient would be a low protein diet with high carb, normal fat, always an advice to avoid prolonged fasting, supplementation with carnitine, and we'll come to it at the end of which cofactors are important to supplement in these patients. So carnitine supplementation, benzoate as a scavenger for your ammonia. And remember one thing, I also see patients where benzoate is, when the ammonia doesn't go down, and the position keeps going up with the benzoate. So in a crisis, you can go up from 250 milligram per kg per day to maybe even 400, but you have to be very careful. You may cause overwhelming of the system and toxicity. So benzoate, if the ammonia is not coming down in a crisis, then we'll come to what we can do. We also give these patients some 7 days of metronidazole per month in order to reduce the propionic acid producing bacteria. We can give a special formula which is low in methionine and valine and free, and is valine free and low in isoleucine. But if the patient cannot afford, you can go on a diet which is low protein, supplemented with carnitine and ammonia scavengers. If you are able to give that expensive formula, you can give more allowance of protein because you do not calculate for this formula the total level of protein in it. So the principles of treatment of organic acidemias and lactacidemias, that you reduce or eliminate the protein intake. You eliminate only in a 6-state admission for a max of 48 hours. Never ever do it beyond that to complete. Too much restriction will become a problem because they will be in a catabolic state. Good hydration and preventing catabolism and putting them in an anabolic state by giving dextrose, treat the acidosis well. So if you look at the dose, it's per kg per hour and max is up to 2 per kg per hour. I frequently see underdosing when the buffer of the blood is gone off. And people are, I think most of the doctors are afraid, just they seem to confuse it with diabetic ketoacidotic states, but here it's a bit different. So you need to give that much, and the max also I put there for you. Unfortunately, we don't have IV carnitine, which they need, so you can give it NG, sodium benzoate. And the cofactors, when you don't know which organic acidemia it is, you will go for, that MMA is common in Pakistan, biotinidase deficiency is common, propionic acidemia. So you will go for the cofactors for these suspected ones. You will start the biotin, and you must in such a patient start parenteral B12. Many people start biotin now, but somehow forget to get the B12. So also you would like to give, you don't know the diagnosis as yet when a patient's reports haven't come back and he's sick, and you can supplement with thiamine, because in thiamine responsive MSUD, this should be totally helpful. Riboflavin and coenzyme Q10 for suspected any mitochondrial. At home, they must be counseled in long term on avoidance of fasting, giving high carbs, giving their cofactors, and that the stress of infection, starvation, dehydration, or increase in protein intake can precipitate a crisis. Just some tips now. Guess what kid is this? Now, if you have a child with acidosis, a small neonate or 2 months old coming to you with severe acidosis, ketonuria, and very severe neurological manifestations, unlike your PPA, which has encephalopathy and an MMA, you should think of maple syrup urine disease, which is a defect of branch chain amino acids. So this is one of the MSUD patients. They arch, and they're like literally, they are so stiff. The arching and seizures and the vomiting, it's a hallmark. If you have rashes of Manilia and you have liver enlarged, severe acidosis, Maniliasis, they're just tips. They may not all be, every time it's not the same. Think of methylmalonic acidemia. If you have a child who was okay normal till 3 to 4 months and started having myoclonic jerks, started losing his hair, there's rash on the skin, think of biotinidase or holocarboxylase biotinidase deficiency, which is totally treatable with a good majority of the times with an adequate dose of biotin. If you have a neonate who's never been fed, and before he's fed in the nursery, he gets severe hypoglycemia, acidosis, ketonuria, you got to think of gluconeogenetic defects. And this is a classic prototype of fructose 1,6-biphosphate, because they will not even, because majority inborn errors, they will be fed and you will have a manifestation. This can have one without it. So some examples from our clinics, our OPDs, our department. This is what I was talking about. This 8-month-old, developmentally delayed, perioral, perianal rash, mildly acidotic, hair loss, vomiting and rash settled after we gave. Now you can see that we gave not only biotin, but we gave B12 and we're not sure which. We are thinking about biotinidase, but you have to wait for the results. And she is absolutely a normal, happy girl now. But if you delay the treatment, they will have some consequences on the neurological and on the development. It's an oft misdiagnosis. I see them sometimes as a diagnosis of myoclonic epilepsy or a cerebral palsy, because they also develop deafness later. And this is the child's genetics. So which ones did we see? You can see that in Pakistan, the peak ones are the MMA, the propionic acidemia, the biotinidase. Now, so if you miss a MMA, which is, I'll come to it, one of the treatable ones with us, it would be really tragic. I put HMG-CoA lyase over here, though it is one of it's considered a fatty acid defect, but because it comes like in organic acidemia, I just put it here also for you. Now, talking about the phenotype genotype correlation. Sometimes when I talk to a doctor, they say, "Oh, but madam, क्या फायदा है MMA को treat करने का? वो patient तो 40 हो जाते हैं." They have, but remember, you have different genotypes. This will produce different phenotypes, and in every inborn error, there is either a neonatal form or an intermittent form or a later onset form. So we cannot ever think that there is a doomsday news, particularly with MMA. Now, in Pakistan, thankfully, if you go back to that graph, you'll see we have a whole bunch of CBA1A and 1B, which is a B12 responsive methylmalonic acidemia. And these children, we have to give parenteral MMA. We have had kids coming to us on wheelchairs, literally, and walking out after a couple of days. So this is one of the such patients. Now, if you don't have a B, on a genetic, if you have an MMA mute, still you need to give a B12 trial. But these are the difficult patients. Like, for instance, this little baby, despite all we did, could not make it. But this little girl who came to us, even though she does not have CB1A, this one came with bizarre behavior, loss of speech, ataxic gait. Now, she was referred as a query Rett syndrome for genetic testing. We suspected her to have MMA and we gave B12. We took the genetic testing, and you can see that even though she has one of the difficult types of CB1C, which is a combined methylmalonic homocystinuria, and this gene is pretty common in Pakistan, she responded to parenteral B12. And she's doing very well on methicobal, on L-carnitine, and she goes to school. As you can see, she's enjoying her life. So same with propionic acidemia. We have different phenotypes depending on the level of enzyme that they have. For instance, look at this 12-year-old, which we diagnosed some years ago, who's doing very well in school. I mean, versus this 2.5 months old who's recurrently admitted with acidosis in crisis. Now, talking about the chronic, I told you there is acute pictures and there is chronic presentations. Like, everybody doesn't come to you with a crisis. Like, it's easier to diagnose a patient in crisis. Now, this little 1-year-old came to us with delayed speech and language development, dystonia, feeding difficulties, and on basal ganglia, on the MRI, there were T2 hyperintense basal ganglia lesions and hyperreflexia, hypertonia. Now, it's important not to miss this very treatable glutaric aciduria type 1. Now, that it's so tragic that when we miss them, we miss the boat of treating them in time. And sometimes you have misleading metabolic tests and you have to go to genetics, because in this particular patient, she had multiple diagnoses. On the plasma amino acids, she came to us with severe acidosis, ketonuria, high ammonia, metabolic crisis. And so on plasma amino acids, she was labeled as a ketotic hyperglycemia. We thought about propionic acidemia. On urinary organic acid, it was said to be a biotin responsive MCD, but she actually turned out to have the succinyl-CoA transferase. So sometimes it's important to go to genetics, because this is a disorder where there is inability of the body to break down ketones, and it causes recurrent episodes of ketoacidosis. Just frequent meals with large amounts of carb and restriction of high fat and high protein makes life easy for them. I'll talk a little bit about the lactacidemias. We have a whole bunch of fructose 1,6. This is the dream to treat if we diagnose in time. And many of my families come to us with having lost 2-3 children and if you look at the algorithm, which I first showed you, and I'll go back to it, that if you have acidosis, you will do lactate. And if you have abnormally high lactate, but you have normal lactate to pyruvate ratio with low blood sugar, you think of hereditary fructose intolerance. And this is a prototype. Recurrent episodes of metabolic acidosis, ketonuria, normal ammonia, elevated lactate, normal lactate to pyruvate ratio, abnormal liver tests during episodes with a significantly enlarged liver, having repeated episodes of hematemesis during the acidosis. And they have lost 3 children before. This baby is doing well. And So nothing much on organic acids, nothing much on quantitative plasma amino acids. Mostly you can make a clinical diagnosis, but he also had a genetic proof of fructose 1,6 biphosphatase. And all you need to do in these patients is to avoid fasting, to avoid an overload of fructose and sucrose, make sure that they don't have a period of fasting more than 3 hours. And when they are sick, they need to you make sure that they get the 6-day treatment with fluids, with carbs, with dextrose, and you treat their acidosis. They come out of it very quickly. Lastly, coming to these two disorders, fatty acid oxidation defects and the urea cycle ones. Now, fatty acid oxidation defects are the most poorly understood and underdiagnosed in Pakistan. And they're so it's good to treat them because the child does so well on treatment. And you can see that we have a fair bunch of the primary carnitine deficiency and the carnitine palmitoyl transferase, the CPT1. We have the HMG-CoA lyase. Now go back to your acidosis slide. So remember we said that if you have acidosis, you must do your ketones, and if they are absent, you think of fatty acid oxidation defects. Many of them will have raised ammonia. Many of them will have abnormal liver functions and an elevated CPK. They have a hypoketotic hypoglycemia. So there are inborn errors of metabolism due to disruption of either the mitochondrial beta oxidation or the fatty acid transport using the carnitine transport pathway. Now, presentation, if they come in the neonatal period, is devastating, and they have severe symptoms of cardiomyopathy and liver dysfunction, hypoketotic hypoglycemia. You may not be able to save them. Later on, they come with liver dysfunction and hypoketotic hypoglycemia, and you can save all of them. In adults, it's an episodic rhabdomyolysis. We won't go into that. The treatment, again, for the infants and the older patients is just avoidance of fasting and aggressively treating them during the stress phase. Sometimes we supplement them with carnitine, but it's important that these long-chain fatty acid oxidation defects, you must restrict the fat and give them MCT. Supplement them with DHA and prevent also fat-soluble vitamin deficiency. This is one of our patients who the family lost 2 stepdads, one of the fatty acid oxidation defects, presented to us at 1 month with convulsions, with metabolic acidosis, hypoglycemia, raised ammonia, but no ketone urea. Organic acid urea shows greatly increased secretion of 3-hydroxy 3-methylglutaric and related. So that means he was also positive for the HMGCL gene, which is basically, as I said to you, it is an HMG-CoA lyase deficiency. Now that child actually is doing very well. This is on follow-up. Again, a boy admitted to us with hepatic enceph, disproportionate encephalopathy to any liver insult, INR serum albumin normal. Think about you must think of a metabolic disease in such a patient. And he is the one who showed us carnitine acyl carnitine translocase deficit. Treatment is a dream. They all get well. The various amino acidopathies now. The common one which we are seeing is not phenylketonuria, I have to say. The common ones we are seeing are tyrosinemia, the MSUD, and the glycine encephalopathy. So they're different from the West. It's a diverse presentation. And the most prevalent symptoms in the aminoacidopathy group are developmental disorders and convulsions. The prototype MSUD, phenylketonuria. In some, like hereditary tyrosinemia, there's a predominant liver involvement. And look at this kid with hepatorenal tyrosinemia, coming with liver failure, and all these kids who are well on the treatment of tyrosinemia on nitisinol. When coming lastly to the urea cycle defects, remember we spoke about it, no acidosis, abnormal plasma amino acid profile, think of a urea cycle defect. But the urea, if it is acidosis, you might find high ammonia in, as I said, in organic acidemias and in fatty acid oxidation and in mitochondrial disorders. But pure urea cycle disorders, they have just high ammonia, and your ABG will show alkalosis. I have to run over some of the slides in the interest of time because I don't want to take more time. But remember one thing, that they will come very shortly after birth. More than 50% will be shortly after birth. Either it will lead to death or severe neurological handicap if we don't. Many survivors, despite treatment, have handicap. And despite the existence of effective therapy, even liver transplant is an option, outcomes they're not really good. The incidence is not very is thankfully they're not that common. But the treatment we must put in that it's low protein diet but not protein free. You give an essential amino acid mixture in order to avoid the deficiency of essential amino acids, and you give ammonia scavengers. Now, unfortunately, the only one we have in Pakistan is sodium benzoate, but phenyl acetate, butyrate, and even carglumic acid available outside. The conjugates from benzoate and butyrate are excreted in the urine. It's important to supplement them with arginine. So you suspect urea cycle disorder, start them on arginine and also on citrulline to maximize the ammonia excretion through the urea cycle. Sometimes you might need dialysis. And this is a typical urea cycle disorder. This kid is doing really well on protein restriction, oral citrulline, benzoate, and he's a position holder actually. We're really proud of him. He has this diagnosis of hyperodinathemia, hyperammonemia, homocitrullinemia. This was a family where they had lost 3 kids. None of the kids came to us; they just had pictures. The only child who survived is when we did the carrier testing, which showed a but this kid, surprisingly, even though he has arginosuccinic acid lyase deficiency, on treatment to this couple who never had any child, who is normal, is now doing well. Now, because nobody saved a sample, we had to test the parents, and the parents had lost all their children. And way before 15 days of life, everybody died. So if you are having such a child and you don't know what it is, save the urine sample for organic acid, the blood sample for HPLC, 3.5 ml in EDTA for whole exome sequencing, and sometimes, because we have the facility available for skin biopsy. So I think it's very important, coming to the end of it, that when you have patients with inborn errors of metabolism, counseling and disease prevention is important. The quest for normal leads them to have babies after babies, as you can see from this pedigree, who die. They die without a diagnosis, they die without treatment. Frequently, the woman takes the blame. So I think prevention of all these parents have more than one child with genetic disease. So a big challenge is prenatal testing, and which we have been doing, and we have done more than 200 over the past 3 years. It's important that we use the RPMI tubes. I put this in because most of the thalassemia, if somebody's doing in Pakistan, they're using the Eppendorf tubes, which are not good enough now. I was very grateful to the World Society for giving me a Lifetime Achievement Award for our work on genetic and metabolic disorders. So in summary, inborn errors of metabolism are fairly common in our highly inbred community. We need a newborn screening program and multiple newborn screening programs in different provinces to be set up for the common disorders. And we have highlighted by doing testing in every province, and we know which are the common disorders. These are poorly taught at level of both undergrad and postgrad. So as a result, we don't have a lot of experts. Very few centers to diagnose and manage properly. I'm not even a metabolic physician. I was by default forced to do it. We don't have trained dietitians. They're absent almost. Limited availability of diagnostic tests. Most patients die, or they have permanent handicap, or they're labeled as CP sometimes. Specialized nutrition is very expensive and cost prohibitive. We need to have identifications of centers of excellence for diagnosis and treatment of these rare disorders, developing disease database. Development of prenatal testing facility in a country like Pakistan is so essential. We're doing it in collaboration, but we are overburdened. And we need an introduction of a fellowship in inborn errors of metabolism, which will fulfill need of the trained human resource in the long run. So I think there's always light at the end of a tunnel. And in Pakistan, I do hope someday that we are able to have more experts, and not just people like me who are, I'm not really an expert. I was forced to do it. So I continued to see patients for 20 years, and we developed the first center for rare and genetic diseases in the Department of Pediatric Hepatology in Children's Hospital. Thank you. Thank you, everybody.
Thank you so much, Dr. Chima. What an insightful talk. What amazing work you have done. And how fortunate are we to have you as one of our amazing speakers. We learned so much today, not just from the medical perspective and the biochemical perspective, but from a human perspective. Thank you for sharing those really eye-opening cases. I'm sure folks in Pakistan are probably very used to seeing those cases, but for those of us that are not in Pakistan, this is litmus. You know, we need to start working towards a better healthcare for our population. So I have a whole bunch of questions for you. I'm going to try my best to post it to you, and I know that for me, sometimes it's hard to relay the correct question. So if I mispronounce something, or if I say something that isn't the right question, please unmute yourself and ask your question so that it can be addressed by Dr. Chima accurately. So the first question I have is from Dr. Mohammed Zubair, and they would like to know that majority of the hospitals don't have the facilities of second-tier investigations. In these cases, what should be done? Because patients are poor and privately, these investigations are quite expensive. Even lactate and ammonia are not available in the GP level. Your thoughts, please.
Okay, that's a good question, Dr. Zubair. What we did for this was that we established an account with Aga Khan. We tried to do that with AFIP because these are the two centers which are doing the gas chromatography for organic acid. So there is an account with Aga Khan, but we have like a limited. We have about for 62 patients we can do for free. Or then you can contact one of my team members. Then you can send the patient there for sampling, or you can save the sample and then send the patient later on. But we have an account with them, so you can sort of liaison with the team member at Children's Hospital. There is money in that account for 62 patients per year to do for free testing. And ammonia, I think most of the labs are doing now. Shaukat Khanum is doing it, Chughtai lab is doing it. So, and it's not very expensive. So lactate also Shaukat Khanum is doing, not that expensive. These metabolic tests cost 10,000 if we write them from Children's Hospital, and about 15,000 if you write from outside, and free if you use the account which we created in AKU, if that answers your question.
Great, thank you so much. The next question we have is from Irshad Ahmed, and I think you answered the questions, part of the question already, so I'll reiterate it. It says, is gas chromatography mass spectrometry test available in Pakistan, and at which labs? And I think you said Shaukat Khanum and Chughtai are doing it in.
No. They are doing the lactate, and no, it's available in Aga Khan. It's available in AFIP Pindi, and it will soon be available at Children's Hospital, hopefully, since it's been upgraded to a university, and I'm hopeful that it will come. And I think he's also asking about benzoate.
Yes, he is. Yes, benzoate, is that available?
Yeah, benzoate is available now. Most people think it has to be made every time. Benzoate is available as a powder, and we tell our patients to take a little weighing scale, you know, like the people, like the gold sellers have, or which has the gram weights. Like sometimes you have this in the kitchen as well, and you can weigh the benzoate powder. It's available, the food grade benzoate. It's cheaper, and then you measure it and make the solution for your 1 week, put it in the fridge and give it to the child and make another solution. Otherwise, all the main pharmacies do make the benzoate solution, but it's not available at every pharmacy. So it's hospital pharmacies or main big pharmacies, but make it yourself. They can buy it from the store.
Next question is from Irshad Ahmed as well, and they want to know, why would you prescribe metronidazole regarding the children with probably organic acidemia. Sorry, I know I butchered that one.
Okay, so this is because the bacteria produce, there is a lot of ammonia producing bacteria in the bowel, and there is, especially in propionic acidemia, there is the propionic acid is produced by bacteria in the large bowel. So periodically you give 1 week to eliminate those bacteria. That's the reason you give metronidazole. Just like in hepatic encephalopathy, you don't want a lot of ammonia being produced, so you give you do give lactulose to have acid stools, or you can give neomycin. But here specifically, metronidazole acts on bacteria which produce propionic acid, so we give it in propionic acidemia.
Great, thanks. The next question is from Dr. Huria Rahman, and they would like to, first of all, thank you for such an excellent learning opportunity. And then the question is there any role of mesenchymal placental cell transplantation in inborn errors of metabolism?
Yes, they're researching on it, but I don't know much about it, Huria. I think, Huria, that's a good question, but maybe I should have updated myself a little more. But I think if one of my experts on the panel, if they know anything about it, placental cell transplant. We are working on, we are working on this induced pluripotent stem cells this is part of our project with the Germans, but you said placental cell transplantation, and I'm not so sure about that. So anybody knows about it? I don't actually.
Okay, we'll move on.
I'll get back to you, Huria, if you send me a message and I'll look for it.
Yeah, that's what I was going to say. We could always take questions and then email you back. Just make sure that you fill out the link that I'm going to put shortly, in just in a minute or two. Okay, so next question is from Dr. Arit Prakash from NICH. And their question is, would these cobalamin defect MMA would need specialized milk formula as well, or this parental B12 is enough to treat and concomitant homocystinemia would need treatment?
Right. Now, coming to the B12 responsive MMA, the CB1A and 1B, there's a lot of discussion about diet and protein restriction. Now, most of the metabolic specialists agree that initially you would restrict. Once they're stable on B12 and you've seen the response, as they grow older, the diet restriction gets less, but doesn't get like full time, they're going to eat steaks all the time, but the diet restrictions get less and the specialized milk gets off, actually, especially in Pakistan, it's so expensive. And they seem to do pretty well on B12 with less protein restriction. So it is there, but not as severe as in other ones. And so it is most of the times not done immediately as the child grows a little and he's stable on the B12. Yes.
Okay. Next question we have is from Dr. Wasima Rahman, and they would like to know, is there any difference between oral and IV methylcobalamin in treatment of MMA
Yes.
with homocystinemia? And is there hydroxycobalamin available in Pakistan?
Your routine methylcobal is enough. And yes, there is a big difference. It has to be parenteral.
Okay.
That's where we make a mistake many times. It has to be. It's like you're, there is a big difference. So the recommended one is parenteral. Sometimes for like a few weeks, and if the child is unwilling, or a few days, I allow them to take the oral 1 milligram, because it has to be 1,000, but not really in the long term. They should continue to take the parenteral.
Okay. Next question we have is from Khwaja Muhammad Arshid, and they like to know, is nitazoxanide available?
Nitazoxanide, yeah.
Nitazoxanide, is that available in Pakistan, and when to start, and which milk you recommend in tyrosinemia?
Okay, so nitazoxanide is not available, and if we make it available at a cost, it is too cost prohibitive. So what we are doing for our patients is we are reaching out to the companies, and we're getting it as an orphan drug on a international charitable access program. You know that Children's Hospital is the biggest center for charitable access. We get enzyme replacements for Pompe's, Gaucher, for Hunter's, and for MPSs, other this for hurlers. So, and we also get nitisinone, and we also get the folic acid. This is all on charitable access because they're cost prohibitive. It is becoming a little issue, and I would like my North American colleagues' help in that, because our families of tyrosinemia are becoming, they're more and more. So our charitable access companies are running out of, like, it's a lifetime therapy. So we are running out a little short on that, and we are requesting more and more companies to help us with the charitable access. But right now, all of them are getting it through. It's not even registered in Pakistan, so it's total ICAP.
Mm-hmm. Yeah, I think I've exhausted the questions from the chat. I think Ajaz and I have one more question. I'll post Ajaz's question first, and then I'll post mine. Dr. Ajaz would like to know, well, first of all, thank you so much for a great, concise lecture. And he would like to know, what is the status of newborn screening in Pakistan, and what's the plan for the future? Status of newborn screening in Pakistan.
Status of newborn screening. Look, the government periodically calls a meeting. Some hospitals are doing it on their own. There is a Alize Foundation, as I said last time, which is a Jordanian-based philanthropic organization, which has offered it to some hospitals, the newborn screening program. Some hospitals have established a thyroid screening, like Fatma Memorial, like Shalimar Hospital, like AKU in Karachi is doing it. So I think we are still waiting for the newborn screening, where you include the metabolic defects, things like 21-hydroxylase or galactosemias, and we don't have that kind of a screening program. Even the hospitals which are doing newborn screening, they're only doing the hypothyroidism one, except for the Alize Foundation filter papers, which they offer, and they are doing most of the metabolic diseases, which are common, some not common in Pakistan, interestingly, because this is based on their data from Arabs. So because this, it's a Jordanian-based thing, but you don't have it. Punjab does not have any program. I don't know about Sindh. They don't have anything in the pipeline except for talking about the thyroid screening. So no, for metabolic diseases, nothing from the government is in pipeline. We gave them papers of, they called a meeting, they asked for stats, and the people who go to the meetings asked me for the stats. I provided them, nothing came out.
Well, thank you so much for
That's the status. Nothing is done.
That is difficult. I have one additional question for you. And because, again, we're so focused on the genetics variants in our field of work, we're always trying to find more and more population-specific variants. And so through your work at the Center of Rare Diseases, is there a database that y'all are keeping, or is there a some Excel file somewhere that's
because it's part of our, it's all the data is, that's why I'm saying bioinformatics is a big thing to us. We are doing, every single patient's data is kept. That's how we published the first paper of some years ago on the 1,000 genomic testing that we did. Our next paper you'll be seeing on whole genome sequencing and its importance in picking up. We also recently have sent a paper where we have picked up on a new genetic disorder. Every data has to be kept because we have to write it up as well. Sometimes we go back to these because where we are sending the bloods, the filter paper is stored and is going to be stored for years for patients whom we haven't come to a conclusion. And we go back again and again to them to say, well, they do have some disease. So we have all the data. Yes, exactly. All the diagnostic, all the clinical one, everything.
That's gold right there. That's money.
That's gold. That is gold. Absolutely.
My follow-up question has to do with the variants of uncertain significance. I saw that on a couple of your slides, while there were certain likely pathogenic and pathogenic variants, and then in addition to those, there has to be a flood of variants of uncertain significance. And I see you smiling. What are your thoughts, and what is your work process around those?
It entirely ultimately depends on phenotype and genotype genotype correlation.
Mhm.
You know, ABCB4 mutation, which causes PFIC3, it's very common in Pakistan, and it is extremely uncommon in the world. When we first started collaboration, I'm a gastroenterologist. I had a whole bunch of ABCB4 suspected ones. So I gave it into Centrogene, and they would come back with variant of ones. I'm like, okay, so this fits the phenotype. So they have classified last year that most of those variants as variants of, they're pathogenic.
Mhm.
And sometimes, yes, if it is a mutation which hasn't been sort of reported that much, and they always ask us, does it correlate with your phenotype?
Mhm.
And if it does not correlate, for me, it will be a variant of uncertain significance. But if it correlates, it will be important. But the other part of it is legally, for instance, in Germany and in UK, you're not allowed to do prenatal if somebody reports it as a variant of uncertain significance.
Interesting.
So I had this issue where I had to talk to them that this ABCB4 is, I need to have prenatal. And they said, well, the law doesn't allow that. I'm saying, like, well, classify it properly. Look at all these patients, they have the same phenotype.
Mhm.
So I think sometimes it is a difficult arena where you have to correlate the mutation. You have to look back at the reports, how they have been reported. Are we reporting enough of those variants also? And the phenotype genotype correlation. So fructose 1,6, for the longest time, they reported as a variant of Hansen. And I said, well, you have 31 patients with this. And now they report it as a variant of a pathogenic variant. So I think there is a borderline zone over there.
Yeah.
Sometimes, yes, you're right. It's difficult to tell. It's a very gray zone.
Yeah. Well, we know at least in United States, there are various labs that will do prenatal testing on variants of uncertain significance. And so if you ever have any cases that you really need prenatal testing on, the variants of uncertain significance can be tested at certain laboratories.
Right,
So you
right.
can work on
Okay.
those.
The
Now,
European law prohibits it. They say,
yeah,
no, you can't. Yeah.
right,
So
but US law
that's
hasn't caught on to it yet. So for us, at least in North America, when we hear that there are all these different variants that have been characterized and they're VUSs at this moment, but then, Pakistani population and other not very well studied populations have so many of these variants, there has to be a reclassification, and then it becomes a pathogenic
absolutely,
variant. And
absolutely.
that's where it is just so important to have a good database, which you are doing already, which is a fantastic resource. And so with that, I believe I've exhausted everybody's questions. There is Dr. Ali Raza, who is thanking you, and Dr. Anjum is thanking you, Dr. Ali Akbar is thanking you, and a whole bunch of other people are thanking you. And Sarah Farhan's child is also thanking you. I'm posting the link again in the chat box. So please take the time to click on that and take that survey and give us your feedback. And if you have any questions for Dr. Chima, please send us those questions, and we'll be happy to relay those questions to Dr. Chima and get back to as soon as we possibly can. And with that, we will conclude today's conversation with Dr. Chima, and a very big thank you to everybody for joining us today. Thank you, Dr.
Thank you, Aisha, and thank you, our North American team, for giving me this opportunity for interaction, and I am really grateful. I hope it was informative to all the doctors, and I hope we continue with, because it's only part of the lecture,
Aisha,
only 1/3 of it.
Aisha, this is Rizwan
Hi,
Naeem.
Dr.
I wanted to say if Ijaz can mention about next lecture, and as all the audience are here, they should know.
Right. Assalamu alaikum, and Dr. Chima, thank you so much for such an informative talk. This is just amazing.
Thank you.
Amazing work that you're doing over there. So we're going to have the last lecture of our series for this year. This will be in the last week of November, last Sunday of November. And we will have Dr. Amanda Freed, who's one of our geneticists here in Southern California. She's agreed to give a talk on disorders in adult population. So it's basically tackling the adult genetics. We've kind of gone through all these lectures where we have started with the introductory, we've done the prenatal, we've done cancer. So we have pretty much covered most of the important major topics or major parts of medical genetics. And so we haven't done adult genetics, and we thought that that would be the best thing to conclude with. So inshallah, we will have a lecture on the last Sunday of November. That would be the last lecture for this year. And then we will continue with specialized lectures next year. So please stay tuned and we'll send you the information.
Thank you, Ijaz. And not last but not the least, thank you to our collaborating organization, Jinnah Sindh Medical College Alumni Association and Lahore Health University of Sciences, Dr. Saqib, and so on, and Yunus. All these lectures, all 11 of them, will be on our website, which is www.psmg.org. So anyone can go back and listen to these lectures as interested.
Thank you.
Thank you.
Thank you. Have a good day.
Bye-bye.
Dr. Chima, if I may ask you one quick question.
Yeah, sure.
If there is anybody in Karachi or in any part of the Pakistan who has a child with metabolic disorders and we don't have experts over there, or you may know some experts over there, what is the channel or mechanism by which they can get patient to any specialized centers like yours or any other centers that might be there?
No, Karachi has, Aga Khan has a metabolic unit. Dr. Bushra Froze, they see, because it's a very expensive place, I think not everybody gets to be there. But again, I am going to Karachi on 8th November with our team and doing clinics in Liaquat National. And next time we'll do them in NICH. So Liaquat National is going to be, they advertised it across Sindh, and patients will be coming there. Plus we are going to NICH, and there is one of my trainees is there, Dr. Prakash, and he will probably, he's also one of those who trained with us. So some patients go to him, some go to Liaquat National, and some go to Aga Khan. So there are centers there for if a patient needs help in this field. Karachi has, at least AKU has Bushra Froze there.
That's good to know. Thank you so much.
Okay.
Thank you, Dr. Chiva, and look forward to see you soon. And if you have that information about your clinic at NICH and
this time we are doing in Liaquat National, and maybe I could send it if I don't have your, I have your number. I'll WhatsApp you the brochure and the information.
Please,
Soon as I'll ask Liaquat National, we are doing clinics for the entire Sindh on 8th of November, which is Monday, I think. Monday, Sunday I'm traveling.
Thank you.
Okay, I'll send you the brochure, definitely.
Yes, thank you.
Okay,
So with
thank
that,
you so much.
we can end this session. Yunus, you can turn it off, the recording, and thank you, everyone. I think Aisha is gone.
Thank you.